So like you said, DB05 was the adjuvant study. And I think, again, they included patient populations that either had inoperable disease at presentation, or if they had operable disease, they had X-ray positivity or lymph node positivity at the time of surgery. And the goal of the study was the 3-year invasive disease-free survival. That was the primary endpoint. And I think the study did achieve that, with a significant benefit to the group that received T-DXd. So the comparator group is T-DXd, the intervention group is T-DXd, and then the comparator group was T-DM1. Each received 14 cycles per the protocol. And I think that what was really important to think about this study is, obviously the natural comparator in our mind is the KATHERINE trial, but I think that, DB05 patient population was of a higher risk. And also I think the neoadjuvant regimens were more emulating real-world practice. So, in KATHERINE, 20% of patients received dual HER2 targeted therapy, but the vast majority, 80% of them received that in DB05. And then the anthracycline use was much higher, over 70% in KATHERINE, and here it's more like 48, 50%. Again, not necessarily our practice. We tend to lean away from anthracycline therapies, but several centers, especially those around the world, continue to use that. So I think they did a really good job in looking at a clinically relevant patient population, one that we see in clinic all the time, and neoadjuvant regimens that really capture, the population, that the way we treat them. So I think that was really good. The secondary endpoints are, of course, not mature yet. And I think the other, amongst the invasive disease-free survival, we did see a trend towards lower CNS recurrences in the group that received T-DXd compared to T-DM1. And of course, the non-CNS recurrence events were also lower in the group that received T-DXd compared to T-DM1.
So, thank you. What is important is this population for DB05 was a way higher risk population than we'd seen in KATHERINE.
Absolutely.
But the approval
yes.
does not specify high risk. So it's pretty close to what you would get for KATHERINE.
Absolutely.
Have you thought about how you're going to use that approach? Which approach you're going to use are you going to re-stratify your patients for a particular approach?
Yeah, I thought you would never ask that hard question. It's true. The label is pretty broad. It says for all patients that have residual disease after, neoadjuvant therapy. And so it does beg the question of, when you have a patient sitting in front of you, how do you do that? Like I mentioned, I'm a recipe follower, so I would tend to follow that recipe. Having said that, again, as Dr. King mentioned, you really have to, it's not one size fits all. Clinical trial does not always inform how you do it in the real world setting, particularly if the label supports that. So if I see that a patient is particularly at high risk and, maybe started off with really high risk features like positive lymph nodes, etc., and have had clearance, at surgery, but still small amounts of residual disease, I would probably, still use that, even though it doesn't strictly meet the same definition. And also I have a conversation with the patient, even if they have small amounts of residual disease, I will let them know that the label does allow you to get it, even if you're lymph node negative or didn't meet the inclusion criteria for the trial. But we have to think about, again, toxicity monitoring, cumulative toxicity for ILD with 14 cycles, and of course the real world tolerance and how many cycles they can get in the real world based on their tolerance.